Hi, I'm Dr. Sarah Berg. I'm a board certified OB-GYN and founder of Selfority. You don't know me yet, but I'm here because after having spent over a decade in clinics with women who were afraid to ask their question or felt shame about the knowledge that they lacked, I created Selfority. Even the name of the company speaks to why we are here. The self part is clear. This is for you to have for you. The ority part is where we make yourself a priority. And that's why I'm so proud of you. You are taking a moment to make yourself a priority. So many women neglect to put themselves at the top of the list. But here's the reality most don't even put themselves on the list. Self-worthy is here and giving you the time to put yourself on that list. You may have heard the saying that action is the antidote to anxiety. Today, we're going to talk about action you can take to understand yourself and to approach conversations with your own clinician without fear and without shame. I'm going to walk you through our guide, Understanding Your Sex Hormone Labs in Perimenopause. We built it because so many of you describe the exact same experience. You have normal labs, you have real symptoms, and no explanation for the gap between them. If you've ever left the appointment holding a piece of paper that says your hormones are normal and thought, then why do I feel like this? This is for you. So let's get into it. I know you. You take care of yourself. You see your physician at the scheduled appointments, well, at least most of the time. You heard from your friends, a family member, or even the internet that you're around the time in your life when you should have your hormone labs run. You finally did the testing because you're really starting to feel off or just not like yourself. But the labs came back normal, which just seems like it can't be right. I have good news. The gap between how you feel and what your lab work says isn't a you issue. It's an information gap, and you can understand if you are given the right knowledge. And over this next 30 minutes, I'll explain what each hormone is actually doing, why timing changes what a lab result will mean. And after each lab we cover, I'll stop for a minute to suggest exactly what to ask at your next appointment. The first thing you need to know is that the standard lab panel was built to capture stable values. And as you may have heard, perimenopause is anything but stable. That's why taking a single blood draw on any given day will not give you the information you hoped for. It's asking the lab to do a job it just wasn't designed for. During perimenopause, your symptoms, your cycle history, your lived experiences are more clinically meaningful than any single hormone draw. That's not my opinion. It's guidance from the American College of Obstetrics and Gynecology, which we'll call ACOG for short, and the Endocrine Society. Okay, here's that first question we talked about. You can ask your doctor, how do my symptoms and cycle history factor into this compared to any lab result? Now, before perimenopause, most systems run on a roughly 28-day clock. Classically, it's actually 24 to 38 days. So you might say, hey, I wasn't a 28 day, that I wasn't abnormal, right? No, 24 to 38 days, completely normal, but it usually runs on that schedule. Your estradiol rises to deliver the follicle and peaks before ovulation. Progesterone rises after ovulation and falls if a pregnancy doesn't occur. FSH stays low and stable. LH surges at mid-cycle, then returns to baseline. In a regular cycle, timing is everything. So if you draw a progesterone level on day 5, it's going to look completely different than the draw done on day 21. And it's not because anything's wrong, but because that's how progesterone works. The timing impacts the information. Drawing a lab without knowing where you are in your cycle is not going to be a reliable indicator. Okay, now we have that next question to ask. Should this lab be timed to a specific day in my cycle? And how do we account for it if I can't predict my cycle anymore? So perimenopause is, as you probably know, a multi-year time of hormone volatility. It usually starts in your late 30s, early 40s, and it runs on average for 4 to 8 years. But for many, it can be even longer. And that's the time before that final period. During perimenopause, estradiol could spike higher than it ever was during your reproductive years, then crash, and sometimes within the same week. Progesterone often drops earlier than estrogen does in a stable way because ovulation becomes irregular, and without ovulation, there's no progesterone production. So pay attention to this one thing. This is a pretty cool new development that I think makes a lot of sense. There's emerging research suggesting it may not be where your hormone levels land that drive how you feel, it's how much they fluctuate. So this makes sense. Take two women with identical estradiol numbers. They can have completely different symptom experiences. And we know that. And that's why that number isn't really something that we need. It's because that single static measurement cannot capture the variability. That's exactly why your lab results and your lived experiences don't match. Okay, here's another ask your doctor moment. If a hormone lab value isn't going to change how we approach things, is it still worth doing? And why not? So think about a lab drawn in a clinic like a dot on a graph. If it happened to land on a day when estradiol is at its peak, the results will likely come back flagged as elevated, even though if you were to check 2 weeks before or 1 week after, the number can be completely different. That's especially challenging because perimenopause is a multi-year pattern, not a single moment event. So in other words, your results can look completely different depending on the day you have a lab drawn. One data point is real. It absolutely is. It's just not the whole picture. Truthfully, it's not even a piece of it. This is exactly why ACOG and other major guidelines advise against using a single FSH drawn to diagnose perimenopause if you're after 45 years old. The day-to-day variability makes one value completely unreliable. One draw might fall in the menopause range, while the next one might not be at all. So ask your doctor. What would help you get a clearer picture of what's going on with me? Many women don't realize that menopause is actually a single day event. I know we always talk about menopause as the whole enchilada, and that's kind of usually why I call it the menopause transition because that word is so ingrained in us. But the true definition of menopause is just 12 months without a period. So 12 months after that last menstrual period or your LMP. And once you've had that final period and it's passed, this is a new stage. This is when the hormone picture stabilizes. That snapshot problem you had and we all have during perimenopause, making it so hard to capture, no longer applies. Because think about it. There's no more cycles. There's no more mid-month surges. There's no more luteal progesterone. LH just remains stable and elevated a little bit. Estradiol settles into its new stable baseline. And then FSH has risen because remember, that's the one that's telling pituitary to get to work. It's risen and just stays up. And truthfully, it's after your last menstrual period, that 12 months after, very likely you would be able to use the FSH as an actual number to diagnose that exact idea. Because if it is at or above 30, that is a meaningful point. So, in other words, menopause is an important day. From here on, the chaos stops and the tools finally match the moment. Ask your doctor moment. Now that I've reached menopause, which labs, if any, do we still need going forward? Okay, I know you thought I forgot about this, but I absolutely never would. The next thing we're going to talk about is testosterone. And the reason we've separated it out from the talk about estradiol, progesterone, FSH, and LH is because testosterone does not follow the same rules as those hormones. Everyone across the board, starting in your 30s, while the other hormones could be crashing up, down, they're completely variable. This is when testosterone begins to steadily and slowly decline. And it does it completely independent of the menopause transition. They are not linked. I always like to call it the escalator versus the elevator. Testosterone declines like an escalator. It's slow, it's smooth, it's just a little trajectory down. And you can see that on the slide. Where estrogen is going like an escalator, up, down, up, down. It's like, well, it's like the kid in the escalator pushing all the buttons, sending you up and down and up and down. The loss happens with testosterone whether or not you're in perimenopause, which is important clinically because testosterone declines on a different timeline and by a different mechanism. Its measurement and its treatment are governed by different evidence. So currently, research on testosterone for fatigue, muscle mass, mood, and all the other symptoms you see here listed out are mainly still in development. The current evidence only supports testosterone therapy to be applied for low libido. Ask your question, ask your doctor moment. So, based on my specific symptoms, is testosterone therapy something the current evidence actually supports for me? Now, as we've said from the start, standard hormone labs were designed to capture a stable value. And perimenopause, by definition, is anything but stable. That means your experience and your symptoms are the most valuable data we have during that time. Hear me again. Your experience, your symptoms, what's happening to you, what you have documented, what you know as yourself. Those are the important factors you want to bring to the office because perimenopause is a clinical diagnosis, and that makes it our whole job to listen to you. It's not diagnosed by a lab value crossing a certain threshold. You cannot expect to apply the same tools across different fundamental biological contexts and get complete correct results. That's not a failure of your doctor's knowledge, and it is definitely not your body not coordinating and cooperating. It's simply the instrument is limited in that way. We know the single dot is not telling us the whole story of how you are feeling. This is the reality of perimenopause, and it's exactly why it's so important to go into your clinical appointment self-aware and prepared. Know which labs you had, when they were drawn, and where you were in your cycle. Be prepared to start the conversation. Don't wait for the lab results and the question from your physician. Don't worry, we'll send you the slide deck after we're done. It has the specific questions written down, just the ones we talked about are the great ask your doctor moments. And we'll also send you an exclusive 20% off discount code you can use on Selfority to learn more about everything we've discussed today. So you're equipped to get the care you need and that you deserve. So a little bit more ask your doctor moments. Of course, we're here for that. The first one is, what are you looking for to figure out if this is perimenopause? My symptoms, my cycle history, labs, or some combination of it. Next, how does my symptom and cycle history factor comparable to the lab results? Another one, if labs aren't going to change how we approach things, is it still worth doing? Why or why not? And then finally, what's the most useful thing I can track or bring to our next appointment if a single lab value isn't the full picture? So understanding what these hormones are doing and why timing changes what a number means isn't about becoming your own doctor. It's about walking into the room able to ask sharp questions and advocate for the care you deserve. We started with a promise that you would know what you're experiencing and that it's normal. That is nothing to be ashamed of, and there are actions that can be taken. So here's the easy button for you. At Selfority, we have 2 courses built for this exact reason. There's Menopause Essentials, which covers 5 foundational lessons on your brain, your heart, and your body. And then the whole enchilada, I like to call it, is Menopause Explained. It's 13 module program. It also includes information on hormonal and non-hormonal therapies, as well as bone health. Both are built from the real conversations I had in the clinic for years, answering the questions you've been asking and some that you didn't even realize you were ready to voice yet. Because you prioritized yourself today. You've shown you want to, or at least know you need to care for yourself. We appreciate you and want to support you. So use the code Selfority Labs to go deeper into symptoms and subjects that impact your life. Don't worry, we'll also send you an email with a link in the codes. And now, let's stop for the legalese. As a quick reminder, this is a guide and this session is completely educational. It's not personalized medicine advice. Guidelines evolve, and your own clinical situation should always guide discussions made in partnership with your clinician. Okay, now we're into the question and answer session. And guys, thank y'all for putting in your question. It is so helpful. So I'm going to try to answer a few of them because we definitely have some time. And then feel free to keep reaching out because we want to hear from you. So this first question we're going to pull up is, if my labs are normal, does that mean nothing is wrong? And that is a question I hear all the time. And why, truly, this is the whole basis of why this ebook exists. And the answer is no, absolutely not. Perimenopause is diagnosed through your symptoms and cycle history, not a single lab crossing any line or threshold. Also, some labs rule out other things like thyroid issue or anemia. They're not always meant to confirm perimenopause itself. So even if you're getting lab work, it may be to rule out other things, not to rule in perimenopause. Okay, I've got a good question from section 2, which I think is really cool. So this one is, which hormone should I ask to have tested first? And honestly, there isn't one to prioritize. None of the sex hormones reliably confirm perimenopause on their own. That's the whole reason testing isn't a starting point for diagnosis. If your doctor does order hormone labs, it's more likely they're ruling out something else entirely, which is a different kind of lab than the sex hormone panel we're talking about here. Okay, here's another good one. Is FHH the test that tells me if I'm in perimenopause? And that is a question I get all the time because we talk about FSH as that magic tool to know that next step. But sadly, it's not reliable. FSH fluctuates just like your other hormones during perimenopause. And so it's too hard to pin it down when you're in the transition. It's really only helpful after you've been through that 1 year without a period or officially gone from menopause to postmenopause. Okay, let me look for another one. Okay, here's one. Does it matter which day of my cycle I get blood drawn on? Yes, especially for labs like progesterone. The same hormone can look completely different depending on what day of the cycle you're on. And when you look at that reproductive chart, it makes complete sense. You see, it's intuitively going to rise in certain areas and fall in others. So the timing definitely matters. Cycle timing is something you should always ask if you're going to get hormone labs done. Where am I in my cycle? Or let the doctor or the lab know, because that's an important part of knowing what's actually going on. Oh, this one kind of goes along with it. If my cycle isn't regular anymore, does that change things? Yes. Once your cycle becomes irregular, timing a lab to a specific cycle day gets so much harder, which is part of why perimenopause testing is just tricky, to say the least. So if your cycle isn't regular and we can't say, yes, it's always day 3, always day 7, we know when to come in, it does make it a lot more difficult to get the correct information that we're actually looking for. Okay, looking. Oh, here's one. Why do I feel so different week to week during perimenopause? That is, I feel like that's the hallmark. And it's because your hormone levels generally are swinging more than they ever have right now. And we've lived our whole adult lives with some swing of a hormone, but it's become cyclic. We kind of have a feeling I may always feel this way before my period, or this way when I ovulate, or this way after my cycle. But this is taking it to a new level because it's taking the expected and it's removing that, which is so jarring. And so, yes, they are generally swinging all over the place, which, as we talked about, could be the reason why people feel symptoms differently. How much they swing and how they swing, because we are all individual and there's no cookie cutter and we're not one size fits all, markedly depends on what, where, when, why of our symptoms. Okay, here's one. Can I have perimenopause symptoms while I still get a period on schedule. So that's a little bit of a tricky one. It's not a yes all or no all. You can have symptoms without your cycles looking irregular yet. The cycle changes don't always show up first. And I do hear a lot more women saying they've had mood issues. They didn't realize it was going on. And then their cycles started becoming irregular. And then the puzzle pieces came together. But they hadn't thought of perimenopause as a reason before that fact. And that is absolutely something to think about. Because once anovulatory cycles start happening, your cycles tend to become more irregular because you're not on a normal schedule anymore. Your hormones are doing what we kind of showed earlier when we were talking about it. So a still regular cycle isn't a sign that nothing's changing. It just means that irregularity hasn't caught up yet. And for some people, even the first few anovulatory or not having the ovulation in the middle of your cycles, people will still have regular periods just because their body is kind of in a routine and it's giving you a withdrawal bleed. So it is uber complicated, which is why it can be so hard to diagnose. And that's why keeping up with all the symptoms is an important part of bringing the information to your physician. So, this is a good one. I think it goes with what we're saying and what we've been talking about. And I like that you put it out here. Is getting a lab test a waste of time? The answer is no, because you're often getting tested for other issues that could present like perimenopause symptoms, but aren't perimenopause. And so it's one of those ideas like not everything is perimenopause and not everything isn't perimenopause. And sometimes we have to do a little detective work between the two. So the lab work you're likely getting when you go in and you say, here's my symptoms, here's what's going on, is looking for other reasons where you might be having the symptoms that are treatable, testable, and changeable. And so it's always good not to just assume something is perimenopause, but to rule out other reasons. So think about things like your thyroid or you're anemic or vitamin D is low. More to come on that later. But just know all labs aren't sex hormone labs. Okay. Okay, here's one. So once I'm actually in menopause, is a single lab test finally useful? And finally we were able to say yes. An FSH over 30 on any given day becomes a meaningful, stable signal that the transition is behind you. So you're now postmenopausal. And there's no reason you have to keep checking. Once we know, but that's the hormone level that can be helpful if you absolutely want a lab value on it in that point of the menopause transition. Here, do I need any ongoing hormone labs after menopause? Kind of going right from what we just talked about, not typically to confirm you're in menopause because we've already confirmed it. But like we talked about before, also, there might be other labs that are necessary for other reasons. So, yeah, you'll need labs, but they might not be around the hormone changes. Okay, a testosterone one. I knew there'd be one. Should I ask for a testosterone level check? So currently, the only indication to check testosterone levels is if you're starting treatment for low libido. So we have a baseline level so we can keep track of it from there. And then usually a few times to just make sure we're not overdoing it on the testosterone treatment, because giving too much testosterone can have side effects that are very important to talk with your clinician about. So, unlike anemia or thyroid issues, there isn't a low level you need to treat. There's just your clinical story, the low libido that we know that we'd be starting at 4. So, if someone comes in and says, your testosterone's on the floor, but you're not necessarily having that symptom, there are a lot of reasons why it could look like that on the lab. And I actually talk about this a lot in my courses, why it can look like that, even though you're not hitting the symptom that is usually associated with it. Here's one. Can testosterone therapy help with my energy or brain fog? So evidence right now specifically supports testosterone just for low libido. Research on these other symptoms that you might have heard about and you've seen people promote and talk about and how they've had a personal experience with, the data is mixed at best at this point. So we definitely can't say as a guideline that it's going to make those changes. I am so happy for people when they use a treatment and they have an unexpected side effect result that is helpful for them. But we can't say across the board that the testosterone may have been doing that. So it's important to keep in mind that a personal experience isn't evidence-based treatment. Okay, I think we have time for this one more question, so I'm going to fit it in because I think it's an important one. What should I bring to my next appointment? This is the whole enchilada question. So thank you for bringing it up. So bring a running list of your symptoms, your cycle history, plus any labs you've already had and knowing when they were drawn. We've gone through this important question today and we've gone through this information. And I think hopefully that this makes a lot of sense to you now because your clinical story is the diagnosis criteria we need. So when you come in and you've been following, keeping a journal, putting notes in your phone, what, when, why, what, where, like a detective of your own body, you are going to have the best conversation with your physician because you're answering all the questions that they're going to be coming in with. So I'm glad you asked that. I love it finishing on that question, and I hope it helps. So we've gone through some really important questions today, and I know it's a lot. So we will also email them to you as well. We'll do the code. We'll give you the information about the classes, and we'll send you this so that you can have it in your back pocket. Because hearing it once is great, but having it in your back pocket to review again, especially before the appointment, it's just kiss. Thank you guys.